Hello, and welcome to a very special podcast that is part of a series I'm leading on diversity and inclusivity with CME Outfitters. Today's CME cast is entitled Irregular Care, Racial Inequalities in the Management of Cardiac Rhythm Disorders. I'm Dr. Monica Peak, and I'm a professor of medicine at the University of Chicago. I'd now like to welcome Dr. Nisha Jilani, assistant professor of medicine at Columbia University Irving Medical Center. Dr. Jilani, I'm honored to have you joining us today. I'm excited about the discussion.
Thank you so much, Dr. Peak, for the introduction. I am also very excited to be here. I think this is a very relevant topic, a very important topic that doesn't often get the attention it deserves. So I'm very excited to be here.
Wonderful. Let me begin starting with our first learning objective, which is to assess the role of systemic inequities and interpersonal racism in the disparate care of cardiac rhythm disorders. Dr. Jilani, in your work on inpatient medicine at Columbia, you've seen the disparities in cardiac rhythm disorders firsthand. What are some of the data that you have for this?
Thank you so much for asking that question. Yes, so we know that cardiovascular care heart disease is obviously a major problem in the US. It's the #1 killer of both men and women. We also know that minority populations have disparate care, risk factor burden, treatment of various forms of heart disease, and also inclusion in research. We know that Black people have much higher rates of cardiovascular disease, up to 47% increased risk. We expect that number is going to rise to 50% by 2035. That equates to a decrease in lifespan of Black people compared to their white counterparts, and also an increased risk of mortality from cardiovascular disease as a whole. It's not just specific to Black people. We know there are similar statistics for Hispanics, and then as well as Native American people, for example, have an increased risk of mortality from cardiovascular disease as well. In fact, at even younger ages. Now, a lot of this has to do with genetics. A lot of it has to do with risk factors in families for various conditions that lead to future heart disease, lead to future heart rhythm disorders, things such as hypertension, diabetes, obesity, but also socioeconomic factors that equate to the types of diet and exercise capabilities that people have. Also, their access to healthcare, their trust in the healthcare system. These are all an interplay that leads to the disparate cares that we see. Specific to heart arrhythmias, mortality, stroke, for example, one of the risk factors for stroke is atrial fibrillation, which is a heart rhythm disorder where there's abnormal heart activity of the atria that can lead to future, annualized risk of stroke. It's unclear. So we know that Black patients have a higher risk of stroke. However, there's less rates of clinically apparent atrial fibrillation in various studies. And it's unclear whether it's because they have an increased risk of stroke from other disorders, or if it's because atrial fibrillation is actually undiagnosed in a large majority of these patients. For example, if you look at the ERIC study, which had 15,000 participants over two decades, there were about 2,300 cases of atrial fibrillation. And compared to white people with atrial fibrillation, Black people had twice the risk of stroke, cardiovascular disease, heart failure, and mortality related to that. And there was almost a 2 times increased risk of heart failure in those patients. And if looking back to the earliest studies, going back on stroke mortality rates, back to the 1950s, there has been a progressive decline in mortality from stroke amongst all ages of white people, of white populations. But there remains an increased risk amongst minority populations, mostly Black patients, African American patients, in comparison. And part of that is for all of the things I just mentioned, because they're less likely to see doctors for preventative care. When they do arrive, there may be systemic biases, systemic issues that lead to underdiagnosis and undertreatment of risk factors or established cardiovascular conditions, all of which can lead to an increase in the downstream sequelae of those conditions.
That's really interesting. And one of the things I always think about with AFib is that sometimes it is something that comes to light when people are presenting with palpitations. And so that may be a clinical symptom that may not be significant enough for people who are already reticent to enter the healthcare system to precipitate them coming to the doctor. Chest pain, that may be, yeah, we all know chest pain, you're supposed to go, but palpitations, people may just, disregard that as something that's meaningful enough to come. And so I can imagine a number of reasons why why that might be underdiagnosed. The medical data also reveals a significant gap in potentially life-saving procedures in interventional cardiology and electrophysiology, which you're a specialist in. We know that there's a gender disparity and a racial disparity. So Dr. Jelani, just how big are these disparities? Can you talk about those for a bit?
Absolutely. So to clarify, so I run a very busy inpatient service, clinical service at Columbia, where we have primarily interventional cardiology patients. So we're very, very well versed in this patient population. There are absolutely racial disparities in various interventional procedures. So, the new growing field in interventional cardiology has been the structural heart disease interventions, particularly things like TAVR, transcatheter aortic valve replacement. And if you look, by and large in the country, 91.7% of those cases were white. So this is, something that has a large disparity. Even things like transcatheter mitral valve repair, which is a very exciting area, also by and large, white patients in this that have been done. And then left atrial appendage occlusion, specifically speaking to atrial fibrillation risk. Now that's something where the left atrial appendage is occluded by a variety of different devices exist, but it's something that could take patients off of anticoagulation while still protecting them from the risk of stroke from atrial fibrillation. So this is obviously something that has multiple benefits in this atrial fibrillation population. We find that we are, referring patients who are high risk because of bleeding concerns or concomitant coronary disease, history of, falls or anything like that. But again, above more than 90% of those patients were also offered those procedures were also white. If you look at other electrophysiology procedures, for example, CRT or cardiac resynchronization therapy in our heart failure population, almost 80% were non-Hispanic white patients, about 10% were non-Hispanic Black patients. And so there's absolutely bias in referral, but also maybe even a trust in undergoing procedures or newer procedures, for example, amongst the patient population as well. Like you mentioned, palpitations is not something that people think of as a life-threatening condition or even a preventable condition. Atrial fibrillation is preventable is sort of a novel concept. But I think that when we think of all of these other procedures, valve diseases, CRT, Icd referrals, things like that, there's clearly a bias. Also, even if you look at the PAD population, which we know goes hand in hand, not just with rhythm disorders, but with coronary disease, heart failure, all of those things. Black patients across the US have a 37% increased risk of limb amputations versus white patients, as opposed to doing, complex peripheral interventions that are available at major centers across the country. I just mentioned Icd referrals amongst electrophysiologists. So we know that sudden cardiac death is a major concern. It accounts for a large proportion of cardiovascular mortality. Its greatest risk is amongst patients with heart failure and severe LV dysfunction. And that early referral to Icd therapy, 3 months after goal-directed medical therapy and that kind of thing is key. There have been racial, gender, and then also socioeconomic or insurance disparities for Icd referrals in the past. Recently, amongst the underrepresented minorities, particularly amongst Black patients, Icd placement referrals have increased, probably due to an increased awareness amongst physicians about this problem, and also improvement in the heart failure guidelines for, in the societal guidelines for heart failure management and for electrophysiology as well, in terms of who should be referred and the timing of these referrals.
Great. It's interesting. We, for many diseases, can more closely think about how social and structural determinants of health are related to some disease, like diabetes or cancer or heart disease in general. And it's a little bit more of a stretch for us to think about how arrhythmias may be related to some of these underlying issues of structural determinants and societal inequities. But like almost all health disparities, disproportionate care for cardiac arrhythmias and other cardiovascular disease management is actually rooted in social determinants of health. And so can you talk a little bit about that?
Absolutely. I mean, I think you hit the nail on the head, right? We think of heart disease has so much, especially amongst healthcare providers that have an interest in prevention, which I personally do. I work with interventional cardiology patients, but I think preventing heart disease is so much easier than the secondary treatments, right? I think that, like you said, we don't think of heart rhythm disorders as something that we can prevent through, socioeconomic equality. But honestly, if you look at the risk factors for atrial fibrillation, for example, a lot of them go hand in hand with the other risk factors for heart disease and stroke. So for example, one of the primary determinants of risk of atrial fibrillation is hypertension, diabetes, obesity. So these are common threads that lead to an increased risk of development, but also worser prognosis for all of these conditions: atrial fibrillation, coronary disease, heart failure. So I think absolutely there are social determinants that are absolutely present as it relates to heart rhythm disorders. Nutrition is another one that we don't think much about, but nutrition leads directly to diabetes, or poor nutrition is directly correlated to development of diabetes, obesity. Also, if you think about the rates of alcohol abuse amongst different socioeconomic statuses, we know that alcohol is also directly correlated with the development of atrial fibrillation. And so I think that there's also a genetic predisposition that is, that's higher amongst Black and Hispanic patients, underrepresented minorities, because of, just history and genetics, that increases the risk of these risk factors. But absolutely, there are socioeconomic factors that also increase this burden, which is why we see that socioeconomic inequalities increases the risk not only of hypertension, diabetes, obesity, but also ultimate heart disease, heart failure, heart rhythm disorders. So the downstream sequelae of these risk factors. The interplay between diabetes, obesity, high blood pressure, high cholesterol, this so-called, metabolic syndrome. I think that all of these things have so much interplay that sometimes it's hard to see unless you take a step back and look at the whole disease process. Also, things that we don't even think of as cardiac or risk factors for cardiac disease: obstructive sleep apnea, which is related to obesity, obviously, just disability or dysmotility, not being able to be an active member of society the way that, the way that somebody who maybe wasn't suffering from all of these conditions could interact. So I think there's clearly an interplay of socioeconomic risk factors, but also, of genetic predisposition and just an increased risk of undertreatment or undermanagement of these risk factors. Part of it is a reluctance for underrepresented minorities maybe to go to the doctor as frequently. I know, it's not just underrepresented minorities, it's women, for example. I can speak to women. It's something that I'm passionate about: heart disease in women, how we can prevent it. So it goes hand in hand. When it's not something that's thought of as a priority for society to prevent, to do preventative health, it's something that leads to all of these other sort of interplay of risk factors.
Yeah, thank you so much. So that bit about all the structural determinants of health is what we normally think about when we think about structural inequality, structural racism. And the other part we think about as being interpersonal discrimination or interpersonal racism. And we had a few head nods to that earlier when you were talking about differential care that Black versus white patients may receive when they're coming into the hospital setting. So I want to unpack that a little bit more, because we already know from lots of different studies that are in the literature that interpersonal racism and unconscious or implicit biases are a significant factor in disparities to cardiac care. So again, even with the same socioeconomic status, the same health insurance, same access to care, that African Americans and other underrepresented minorities are not given the same care. So can you talk a little bit about the specific role of bias and interpersonal racism as it relates to cardiology care?
Absolutely. So let's think about this from start to finish, right? Let's say, and let's just make it very complicated. Let's make it a young Black woman who has a lot of risk factors, maybe family history of hypertension, CAD, heart failure in various first-degree relatives, who also has a full-time job, children, limited childcare. That this woman is not going to go to doctor's appointments for preventative care as regularly as she should, right? That's just a reality of life. So that's a reality of my life. But going to preventative care visits is step one, right? Having a physician, having not necessarily a cardiologist, just having a primary care provider who is not just there checking the boxes. Did you get your flu shot? Did you, those things, but is having a larger conversation with their patient, and for there to be a rapport amongst a primary care provider and that patient, to be able to talk about things like family history, risk of future heart disease. That's a conversation that should start at early adulthood. I tell people that you should start talking about it as early as the age of 20, as early as the age of 18. You're an adult now, let's talk about your risk of future heart disease. The reason is that early adulthood time is when people are going to make their lifestyle determination. Am I going to be a person who exercises? Am I going to be a smoker? Am I going to eat healthy, or am I going to buy my food? I think that it's something that is such a pivotal time that often is such a missed opportunity. So let's take that patient who now is, not seeing doctors so regularly, but goes every couple years, is not talking about heart disease risk, now ends up with, let's say, chest pain. Let's just say chest pain because it's an obvious problem that would bring her to healthcare's attention, right? If it was palpitations, this could be undiagnosed for years. If it was hypertension, this could be something that she never felt and that she wouldn't get care about, for 10 years, let's say. But let's say it's chest pain and this patient arrives in the emergency room, is seen by doctors, but because she is in a rush, doesn't want to be admitted, is not overly concerned, or wants to get home to her kids and her job and all of the other things, 10 million things that we have to do, all the other people that women have to take care of, but also because maybe she doesn't understand completely, right? Maybe the medical information is just too much, or maybe there's a mistrust of, having to do too much. Like, I feel fine, let's just, tell me that I'm okay and let me get out of here. So there's a distrust that goes both ways, I think, medical mistrust by patients of the healthcare system, but also this bias in, of offering all of the treatments, all of the aggressive therapies that are available now. And they're not aggressive in the terms of like they're invasive therapies. I'm not saying we should over test or over treat anyone, but I think that there are so many options, things like event monitors, things like, Apple Watches, or smart watches that can detect rhythms when we're talking about atrial fibrillation. For things like CAD, getting testing, being able to print out that testing and have a patient go back to that trusted primary care provider. So I think that there's this big gap when it comes to a buy-in from the patient population, from years and years of medical mistrust, but also from an overwhelming societal burden for all these other things, taking care of all of these other things and not prioritizing preventative or cardiovascular care. There's also one thing that I've learned doing inpatient medicine now. I've been an inpatient cardiologist for 6 years after training. I think that one thing we've seen time and time again is patients like to be taken care of by people who look like them. So if it's nursing, if it's physicians, cardiologists in particular, there is absolutely something to be said about being able to speak in your patient's primary language, I know that, my doctors are all women because I want to be taken care of by somebody who understands my perspective. So I think that having a lack of diversity amongst race, amongst cardiologists by itself is something that's leading to this problem, leading to these inequities. Part of my mission over the past several years has been to increase and educate not only women but underrepresented minorities in the field of cardiology, with the thesis that if you increase leaders in the field that look like the patient population that they're targeting, not just look like, but understand the plight of the patient that they're targeting, that they're treating, that there's a much bigger awareness on the side of the patient, awareness on the side of the provider, but also a trust that develops. I think that ignoring the fact that there are disparities that exist in cardiovascular care is a part of the problem. So there needs to be increased communication about the fact that this is a real problem, and proactive solutions to solve it, such as this program. And then I think also more protocoled systems that treat everyone the same, standards of practice, such as the guidelines, from societal guidelines come out, but also amongst individual institutions specific to their patient population. And how can we make it so that there isn't disparate care when a patient enters our system? So I think all of these things are not only evident, but if you think about that woman who presents to the ED, maybe isn't having an MI, is told, okay, follow up with your doctor. Unless there is a doctor, unless there is a system of trust that patient can follow up with, this is, again, just perpetuating that cycle. So I give the example of chest pain just because it's so much more, like you said, it's more of a red flag to patients. But when it's things like palpitations that may be underlying atrial fibrillation that is not particularly concerning, this is something that's much more easily missed.
Yes, you brought up so many interesting points that are so relevant for our conversation today. The first of which is the idea that socially marginalized groups a lot of times prefer to have someone from their group to be concordant with. And so there's seminal work from Dr. Lisa Cooper out of Hopkins, who has shown that racially concordant physician-patient dyads have better quality of care. There's more positive affect in those relationships, and patients have better health outcomes. And then the other is that there's that landmark New England Journal article with patients presenting with chest pain, and the only difference was gender or race, and that men were had a greater odds of being recommended for a cardiac cath, and that African Americans had less or lower odds of being recommended for cath, and then Black women compared to white men had a lower odds of being recommended for cath. And so even when there's something that's serious like chest pain and all other variables are similar, there's still some sort of implicit bias that's going on that is shaping physicians' recommendations about care for things like cardiac disease. So thank you so much for this wonderful conversation for our first learning objective. What we're now going to do is sort of pivot to our second learning objective, which is to layer on to what we've already talked about and to identify factors in and strategies to mitigate the disproportionate care for minority patients with cardiac arrhythmias. So how can we address healthcare biases? What have you seen that works in your hospital to try and start mitigating disparities in cardiac care?
Absolutely. So I think the biggest thing is education. Like I said, training. I think that it's something that at least I know that city hospitals do this in sort of a very systematic way. There's cultural sensitivity, there's training, there's talking about the systemic biases that do exist within systems and trying to eradicate any factor for bias. I think there's also, like I said, a necessity to have standards of practice so that they can be, put across the across the board, regardless of whether a patient is male, female, black, white. But I think also just learning about ourselves and having conversations with each other. I think talking to other healthcare providers, people maybe outside of your same, whatever your identified um, race or whatever you identify as, talking to other healthcare providers and seeing how they approach different patients. I think also learning something that's been key for me, and it's almost like it's a lifetime of learning, because it's been how many years of medical education and training, and you learn about how important it is to start to understand patients' agendas and patients' cultural beliefs and how that interplays with their medical care. It's something that, being at Columbia, in Washington Heights, New York, has really opened my eyes to what people actually prioritize as their agenda. Is your agenda taking the best care of yourself, getting better so that you can support your family and go back to your way of life, or is it just getting out of the hospital as soon as possible so I can work tomorrow? And so I think women have different agendas than men do. I think the way that we perceive those agendas, we sometimes think of patients who need to get out of the hospital because they have to work the next day as difficult. They all they want to do is get out of the hospital. It's not that. I think it's a lot of communication that needs to improve between providers, between patients. And I think that's where what you were saying about the dyad of having similar races, similar genders, maybe even, makes so much of that easier. And then also coming up with a common language that hospitals can adopt when describing these issues, when talking about gender disparities, race disparities amongst various, and then looking at all of the different specialties across the board in a hospital system. So I think all of that plays into this.
Yeah, there's a term that people are now referring to as structural competency in addition to cultural competency, which is where we're more aware of all the structural obstacles, societal inequities that socially marginalized populations are facing. And so when people are saying, I've got to get back to work, some people don't have the luxury of taking time off. If they can get back to work, they may get fired and then lose their health insurance and their complete source of income for their family. Whereas you and I may be able to take time off work. We may have FMLA that we can activate. And so missing work is not as much of an economic burden for ourselves or our family. And so understanding some of the structural issues that people are living in, I think is part of a competency that all physicians could benefit from as well, and help us, like you said, communicate with our patients a little better. I mean, going back to another thing that you had mentioned as part of equity is guidelines. And so we know that implementing best practices and guidelines can help push the needle as far as cardiac disparities. And so you talked a little bit about that before. And so can you talk a little bit more about that now? What are some of the ones that you would recommend?
Absolutely. Well, we're specifically talking about heart rhythm disorders. And I think let's take the example of atrial fibrillation, a very common heart rhythm disorder. For each of our patients, for example, on my service, in my hospital, we try to systematically address what their bleeding risk, what their clotting, thrombotic risk is, as well as their bleeding risk. So we will systematically look for the CHADS-2 VASC score, calculate that, as well as a HAS blood score before making a decision on anticoagulation. Do we do warfarin, which is much more intensive for patients, right? Regular testing, variable sort of INRs that can come and go based on diet, or do we lean towards DOACs, which is sort of everyone's preference, it seems, these days. We know that regardless of their CHADS-2 VASC, regardless of how they're treated, that Black patients just have a higher stroke rate than white patients, than their white counterparts. So this is something that if you address across the board, we want to keep that gap as low as possible. And that's for the gap is for a number of different reasons. But as long as we treat all patients systematically, we shouldn't be adding to that gap. improving testing, sensitivity, diagnosis, and addressing all these underlying factors. This goes back to square one, right? So preventative care, addressing risk factors, screening for risk factors early and often, and then all of these other, I've mentioned, all of the different testing. Now with technology in 2021, it's so much easier, right? So you can do a 21-day. There used to be, when you wanted an event monitor, patients would have to go home with like 3 wires and a box. Now it's as simple as a patch or stickers that can go on a patient's and stay on for 2 weeks. There's various different non-invasive testing that we can do, blood work. There's even genetic testing, although that's less commonly necessary for our purposes. So I think that having, this goes back to square one, having again, a good patient doctor relationship, and then also having having a systematic way to approach these patients is key.
Mm-hmm. So a challenge in addressing health disparities is understanding when structural racism may be playing a part in a patient's healthcare needs. And we talked a bit already about structural racism, and knowing how to address these barriers and their burden of risk for heart disease. And so let's talk a little bit about that so we can be better at structural competency. I am identifying when that's playing a factor, but then how do we as clinicians in health systems be better at addressing some of the barriers that our patients face?
Oh, this is a loaded question. Our interdisciplinary team is just so, it's just so many people, as it should be, which is what makes it so fantastic. But I think every member of the interdisciplinary team should have an active voice in identifying any barriers to care, as well as any biases, any systemic, even unconscious biases that occur in healthcare. And they do, no matter how much people want to deny them. So obviously there are physicians, there are nurses and care managers and, patient care directors. There's the nursing, leadership and all of that. There's nutrition that plays such a key role that oftentimes just doesn't sort of, even as I think about when I'm reading off the number of people who are involved in the interdisciplinary team, how often do I really have a discussion with a nutritionist? Although when I'm taking care of somebody who has diabetes, obesity, and heart disease as a result of all of that, isn't the nutritionist probably one of the most important people in their care? There's a psychologist and counselor that's involved, which can oftentimes, raise so much awareness about, like I said, the patient's objectives and their trust or distrust of their healthcare. Obviously, a patient's family, I think as a whole, we're pretty good about engaging patients' families, their healthcare proxy, whoever, in healthcare decisions from the start. And I think that that's key for another person to be able to hear. We know that as patients, you have such a limited amount of intake that you can take, right? As an inpatient.
When you're sick.
Yeah, exactly. When you're sick and when it's so overwhelming for so many different reasons, and probably more overwhelming for the underrepresented minority patients that we're talking about. Engaging family early and involving them in every step of the care is key. And then obviously we are so blessed to have social workers and care coordinators and all of those people who help us make sure that once we let people get back into society, how can we help them? And unfortunately, it's just the country we live in. We can do so much, but it's not like you can send a social worker to a person's home to try to fix all of the problems that exist, right? We try as much as we can before we send people out the door, but it's just the reality that we live in. So that's why it's so important to engage family members and community helpers and all of that from the very start. I think that also utilizing community programs is something that's really important. For example, I can think off the top of my head, in New York, there's like a heart failure outreach program for transplant recipients. And so people who are being referred for advanced heart failure therapies, LVADs, transplants, have this whole community, this amazing community of people who they can talk to, who they have, I don't know how COVID changed things, but have regular meetings and have regular events where they speak to heart failure patients that are about to undergo the same thing. So I think having some sort of support system is really key for that. For whoever suffers from the same disease process. And then also just understanding that people don't want to be identified by just their race, by just their gender, by just, any one thing. I think every individual is an individual, and understanding that it's this interplay of what makes that individual, but also this interplay of all of these different things, their access to food, their access to childcare, their access to, all of healthcare, all of the things that will lead to improved outcomes in the future.
Yeah, I think that you named almost all of them. So team-based care, shared decision-making, involving the family. I'm thinking about community-based resources. And I think one of the things that is great about some of our policy changes and some of the technological innovations is that they're aligning to make addressing some of these social and structural determinants of health easier now for health systems. So for example, CMS is starting to make universal screening for some things like food insecurity, something that all hospitals are going to start doing. And there are systems in place where we can not only screen for material needs, insecurities, but have systems that will automatically refer people to community resources so that it is not only the social worker who has to carry all the burden herself or himself, but there's an automatic system so that people, when they transition from hospital settings to community-based settings, then have a whole plethora of community-based resources and social service agencies that are ready to sort of pick the ball up and help them.
Absolutely, yeah.
Yes, exactly. So, so this for me is super exciting. So let's transition now to thinking more about what you said is one of your personal missions, which is diversifying the workforce. So like surgery, cardiology is another medical specialty that has disproportionately few physicians from underrepresented minority populations. So can we talk about why it's important to train physicians in these areas?
Absolutely. I mean, I think we've talked about it previously, but it's so important. Think about you and I. Think about most of the physicians or healthcare providers that are watching this. I know that I want my doctor to be a woman who understands what it's like to be a physician and also have children and can identify to anything that I tell them. When I don't show up to my primary care doctor, who happens to be a man, but that was just that's a fluke. But when I show up to my primary care physician, every 3 or 4 years, because I'm a terrible patient, I want him to understand what it was like, what the reasons why I haven't come in the last 3 years, and the reasons why, why most people, it's not because non-compliance is just a blanket term that we can apply to everyone. Yes, there are people who don't take their medications because they just don't want to take medications, but a lot of times it's because they can't afford their medications or because they can't, they can't make it to the pharmacy. But I think either way, when you look at cardiology as a specialty, like you said, like surgery, the numbers are abysmal. So, 7.5% of practicing adult cardiologists are underrepresented minorities. And that number is so much lower amongst all of the procedural fields. If you look at interventional cardiology, electrophysiology, heart failure cardiologists, for example. So, and then even amongst academic medicine, it makes less than 10% of full-time faculty members are underrepresented minorities in cardiology. And that number doesn't seem to be increasing. And so, there's been a steady increase in women in different fields of cardiology. And I can say I was one of 6 fellows, the one woman amongst 6 fellows my year. But I can happily say that at Columbia, that is not the case. There's almost a 50-50, if not a bias towards female fellows. So it's clearly something that's changing. It's just, I think race is falling a little bit behind. And why is that? Why is it that, could it be that obviously there's not as much, as many Black and Hispanic medical students as there should be. So I think it's so important for all of the reasons that we said, to promote underrepresented minorities is becoming not just cardiologists, but then leaders in their field in cardiology, giving them a voice to share their perspective, which is obviously a unique perspective. Mm-hmm. And the other part of this is research, right? We didn't talk a lot about that. I didn't talk a lot about that during this session, but all of these decisions that we make, all of these guidelines, I talk about the importance of guidelines and the importance of standards, but all of these guidelines come from research. And so we have giant cardiovascular trials, tens of thousands of patients. But if you look at, for example, the AF registries, only like less than 5% of participants were Black. So how can we make generalizations? Is it possible, can we conceive that atrial fibrillation treatment amongst Black patients should be different than atrial fibrillation treatment amongst white patients? Is it different in women versus men? So there are things that we won't know unless we study them. And that's the case across all of medicine, but clearly we need an increase of representation of underrepresented minorities, Black patients in clinical trials. And that's something that should be a key focus of all of medicine societies over the next decade.
Thank you so much, Dr. Jelani. This has been a pleasure talking to you and learning about your experiences and your work. So we're at the end of our session. This brings us to our takeaway goals that each of us can play in helping to end the cardiovascular health crisis and disparities in the United States. And so some of the things that we can think about for our SMART goals are to identify inequitable processes and pathways in the prevalence, screening, diagnosis, and management of cardiovascular disease and arrhythmia disorders in medically underserved populations. Second, develop solutions to recognize, address, and monitor healthcare provider biases in the disproportionate care of minority patients with cardiac arrhythmias. Third, integrate best practices and guidelines to account for the structural racism and barriers in the prevention, care, and management of medically underserved patients with cardiovascular disease and cardiac rhythm disorders. So please join me here at CME Outfitters for our upcoming podcasts and activities on more action steps against health disparities, including an upcoming briefcase, which are patient case studies in cardiology. You can find out about all of the upcoming events that are live and view previous ones on the DNI Hub at the link here. In particular, 2 of our upcoming podcasts will examine diversity and inclusivity in 2 important areas, oral health and dermatology. We'll be adding new content every month, and we really want to hear from you, our audience, on what you need so we can make an impact on these important issues. Please remember to collect credit for this activity today using the Apply for Credit button on your screen. Again, thank you, Dr. Jelani, for your input today, and thank you for our audience for all your work in providing equitable and holistic care to all of our patients across the globe.